I'd like to now go on with the session. It's really a patient-focused session, and one of the things that if you do clinical trials, and I do a lot of them, is the impact of patient-reported outcomes, PROs. And they're not doctor outcomes, they're not the nurses' outcomes, they're actually done by the patients, done through quality of life. And when you look at trials, you really have to look at how those patient outcomes were done, and it's extremely difficult. They're usually in the supplement of the article. They usually, what you want to look for is how many of those patients reported the outcomes and the frequency. And you'll see some trials where it's only 10%, and you'll see other trials where they're 90%. And so it's a really hard field. And so my next speaker is Dr. Cecilia Pompili. I've heard her speak many times, and she's done a very good job of looking at this. And she's a surgeon, so she's going to take us through early stage lung cancer trials and how to build those tools to look at the patient's reported outcomes. So Cecilia.
Thank you so much. Thank you for Jonathan to provide a not easy to answer question. I want to touch only on Mr. Priest's comment about hugging the patient and the role of empathy also in obtaining those information. I think is so important. So thank you for making this point. So these are my disclosures. So when we are talking about considering treatment evaluation strategy, we are always considering three aspects, so three-dimensional view. One is, of course, the clinical outcomes. One is the patient-reported outcomes, and definitely some regulatory outcomes that are linked to each other. But when we are considering, as you said, to implement patient-reported outcomes into these trials, it should not be just a tick box exercise, but we really need to understand how these outcomes are influencing also the clinical outcomes in terms of attrition to treatment or even compliance with treatment. So having an instrument that can help in assessing well those outcomes can also affect our clinical outcomes and potentially how do we make this regulatory decision properly. So the way I will look at this is definitely to look at what is already available in terms of data collected, but also if there are already some guidelines and in picking and choosing the right instrument for our trial or in clinical practice. So ESMO provided for the first time a few years ago the concept of having a value in clinical outcomes. And it's interesting because that value was measured through this magnitude of clinical benefit scale, which is very important when you consider that even in that scale, you have a grading that is affected by the quality of life outcomes. So if you have a decline in quality of life or a change, this will affect your grading. Unfortunately, this is more effective in the metastatic setting. So when you look at the same grading for early stages, this is a little bit not so impactful. So it's not changing the grading, but it's something that they are considering, especially when you consider that there is a need of standardizing those outcomes and those assessments. So the ESMO committee came up with this checklist that you can find online, and just to check also the value of adding in a standardized way quality of life, at least as a secondary endpoint. Evidence, of course, in the instrument that you are choosing of validity and reliability, and of course, some statistically, most importantly, clinically significance in improvement of quality of life. However, so those were the good news. When we look at the inclusion of quality of life endpoint in clinical trials, we look at this graph, and you can see that lung was one of the cancer sites where the quality of life outcome were not enough represented, and there was also like a decline in representation of this outcome. And so we presented this paper at the ELCC, looking at the assessment, quality of life assessment in the resectable space in a clinical trial setting. And as you can see, so no of these trials was involving quality of life as a primary or co-primary endpoint, and only 50% of those who were including quality of life as a secondary endpoint were reporting the results in a statistical way. More interestingly, the results in terms of reporting were even less homogeneous, and half of them were reporting the results in the primary publication, but the other half were reporting only in secondary appendices. So definitely the quality of life results were not enough to be on the paper in terms of clinical effectiveness, but we really need to understand how to provide those data in those publication. And unfortunately, that was not well studied also within our surgical society. So this is a survey we've done within the European Society of Thoracic Surgeons, and we recently updated this survey with also the involvement of the Japanese Society of Thoracic Surgeons, and unfortunately, so only less than 50% of surgeons were assessing quality of life during the pathway of our patients. And again, that was also confirmed in this updated survey. More importantly, we demonstrated in our resected patient that quality of life was also a prognosticator for survival in this patient. So it was definitely having a role when assessed before treatment, more than, for example, some traditionally use parameters for assessing fitness or PS in general. And that was even more interesting when we look at this randomized trial performed in China, because assessing quality of life and symptoms reporting immediately after surgery was also having an effect in postoperative complication in long term, but also in terms of readmission. So 30 and 90 days morbidity after surgery was reduced if we were electronically completing quality of life and symptoms after surgery. So when we look at the data presented, as I said, not always in the primary publication, but also the way that these data were represented is still not so homogeneous, but each trial definitely had a specific focus. So Adaura, for example, was comparing, so very good results, and was comparing the two arms with the SF36, which is a generic instrument, very useful because you can compare to the general population your data. So I think it's very important also sometimes, especially when you have long-lasting therapy. When we look at the 816, Dr. Spicer presented all the very granular data of the subgroup, especially in the surgical space. So I think it's very important because more and more surgeons are asking about, oh, is the patient feeling okay immediately after surgery or after pneumonectomy, or even when there are some complications. So definitely something to explore more. And the Dr. Cascone with the 77T was the first one demonstrating the time to deterioration approach for these outcomes, which I think, again, is very important when you're looking at the holistic pathway of these trials. However, again, the comment that we've done with this study is that, unfortunately, before surgery and immediately after surgery, we were missing the same granularity of this assessment that we had during the cycles. So it was very, very difficult to define the assessment because most of the time was at the first postoperative cycle. So we were not able to define, for example, some reason of not compliance or reduce compliance, so during that period of time. And why do we need so to assess before and after surgery these factors. Definitely because we had already some evidence saying that patient factors as pulmonary function test or in any case PS are affecting postoperative complication. And we showed in our resected cohort that almost 70% of patients have a huge decline immediately after surgery that is going back only after 1 year. So how these factors are potentially affecting the compliance to the adjuvant side is still not well explored. We know that if we want to define the operability, and we had many discussions yesterday at the tumor board session about how do you define this operability, because how the comorbidity around surgery is affecting potentially the postoperative way of the patient to approach the additional therapy. So we had those flowchart, and this is the ACCP guidelines, the ERS and ESTRO and ESTS guidelines have been submitted, and I'm very glad that with Professor Corinne Favrifin, we were able to also add in these guidelines the patient-reported outcomes for surgery and radiotherapy, and because so far the BTS thoracic risk assessment is the only one which is asking, is the patient able to accept the risk of postoperative dyspnea in this case. So there is a mention of patient involvement in this decision in a formal way. So I think that everything is going in that direction because we have some data about the reason why the patient, for example, did not undergo to surgery, and across the trials is a little bit, it's not easy to understand how much the patient's factors are interfering with this decision, because as you can see, that the reporting of this decision is very is different across the trials. So it's physician decision, patient refusal, or patient that is not fit anymore for surgery. But how do we define this is still not very well defined, and I think that patient decision is definitely affected by these factors that we were not able to assess so far. So we look at these are Leeds data. A few years ago, we look also at the attrition to the adjuvant chemotherapy. And as you can see, even there, we had for eligible patient to postoperative chemotherapy, 22% of patients declining the chemotherapy, of starting the chemotherapy, and also the attrition was not only the poor fitness or the comorbidity, but definitely a diverse type of approach in terms from the patient perspective. And this was also confirmed when you look at the adjuvant ICI therapy in terms of participant decision, which is not related to toxicity. So again, I think that there are some factors that we are not yet assessing well, and which can potentially have an effect also on the attrition to this long-lasting therapy. But we have also the option nowadays in the perioperative setting, for sure, to select with the right tools, those patients that potentially may benefit of intervention, for example, aim to improve or optimize some factors that are possible to modify. So that's the reason why I think it is the concept of rehabilitation, and in general, rehabilitation also after surgery are so important. So the McGill group has done an amazing job so far. We've done some work only on resected patients, but these, especially in the UK, there is a huge push in implementing rehabilitation during therapy in general. So we are very glad that we will start this feasibility trial in assessing not only during neoadjuvant therapy, not only the exercise intervention, but also some a lot of factors and how we will be able to assess patient-related factors during this pathway, but also the potential feasibility of collecting also biomarker during the same time. And this will be in two big trusts in North of England. So coming now to the more specific part related to the instrument in itself. Again, there's no unique answer. Unfortunately, there are definitely a lot of instruments available for lung cancer patients. For sure, generic instrument, and then lung cancer specific and more generic. We were able to implement during this big project, 4 years project, to update the LC13 questionnaire for lung cancer patients, and we were able to add surgical specific question to the LC29. But I think that it's very important to recognize what is the ORTC modular approach nowadays. So I'm very glad to be, so the ORTC asks the quality of life group to be inside each cancer site specific group because has this focus of implementing quality of life definitely in their trials. So the modular approach that is common across the cancer site is to have the QLQC30 as a baseline assessment, and then have potentially the cancer site specific, that for lung cancer is the LC29. But unfortunately, that was still a very it was a little bit hard for the patient to sustain those 59 questions, and especially patient that is going through different kind of treatment, so different kind of side effect. So to face this kind of evolving scenario, so the ORTC developed also the item library, which is very similar to the PRO-CTCA or the other library that are available, where you can essentially even link your CTCA to the library item. So if you want to study that specific symptoms, you can go to the library and add at least to the C30 your specific question. So you are doing like a tailored questionnaire that can be definitely changed during the treatment phase, because if the patient is under chemotherapy, immunotherapy, or targeted therapy, those symptoms will be a little bit different compared to the surgical period. And of course, how do you show these outcomes is also very important. We try, for example, in this study to have a more responder analysis, so specifically at patient level, how do they respond to the treatment. That was a study comparing VATS lung resection to SBRT, and we try to plot just to demonstrate how many patients were maintaining their quality of life for in the following 12 months after treatment. And there are also some conversation, again, FDA and also EORTC, about proposing RESIST criteria in terms of having predefined quality of life score, but we still need quality of life as a co-primary endpoint, and so far we struggle a little bit also from a sample size calculation to have those endpoints as a co-primary. However, so does the second part is more related, of course, of what we heard previously, the importance that from the patient perspective, definitely toxicity, it doesn't stand exactly as tolerability. So we really need to understand how the patient is coping with those treatments and how these side effects are potentially affecting their quality of life, and so the decision to be on treatment for a long time. So concept of interest, this is also from a regulatory standpoint, because especially, FDA for sure was more interested so far to the symptomatic adverse event and specifically the overall burden of side effect. So those are treatment treatment-related effect. And from a more clinical standpoint, we were also interested in the functioning and disease-related symptoms that are not always related to the treatment in itself, and they were lasting of course, beyond the treatment period. So those are the main side of how do you potentially see the best tools. And so the idea of co-design trials with patient representatives is also very new. And I mentioned here a couple of examples because the Libretto 531 was one of the first one incorporating as a secondary endpoint comparative tolerability. So I think, again, that was a very new way of proposing a patient-centered approach as secondary endpoint yet. But definitely, so it was presented at ASCO, and the Cocoon study design was one of the first studies having as a primary endpoint the effect on patient of this side effect. So how can we potentially decrease the effect of this drug on a patient perspective? And I'm always quoting Jill on that because she was PI for this quality of life subgroup analysis. So I think this co-design approach will definitely be more integrated into the trial design. Because of course, with the patient-reported outcomes measure that we have so far, we are not assessing the toxicity. So as you can see, there are several instruments that are used, and there's no standardized way to assess them. And EORTC, again, we are now starting the phase 3 of this potential item library related to the patient-reported outcomes, in particular quality of life issue that need to be assessed in cancer patient during ICI treatment. So new specific items and symptoms, as you can see here, are mapped against what is already available and what we can potentially add to the main C30. And Dr. Naidu will, of course, come after me, but the work that she's done is great. The Hopkins work on the unmet need. These are the two last concepts that I want to stress, because all these great projects show that essentially unmet need in physical, social, but also medical ones are affecting quality of life, are affecting how the patients are definitely coping with this long-lasting therapy. And these are also toxicity in survivors more than 1 year after lung cancer immunotherapy. So just demonstrating that these are long-lasting toxicity, but the toxicity is affecting quality of life because you have unmet needs that are not well studied before from the beginning. So, and the other last concept is, of course, financial toxicity from a patient perspective. This is the Lung Cancer Europe survey on financial toxicity, and as you can see, a lot of lung cancer patients are still experiencing those struggles, and the same has been done within the Longevity Foundation. So again, survivors and patients that are on long-lasting treatment are coping with this treatment also from a financial and holistic standpoint that probably we need to focus a little bit more. So this is just, sorry, it's not showing well the other table, but essentially, so that was Lancet Oncology paper that has been done across Europe to define essentially how the regulatory agency were incorporating also quality of life data into the approvals. And what you cannot see, but I can tell you, so is that across Europe, including UK, so even if it's now outside Europe, so NICE was there was not a standardized way of considering quality of life. So some HTA bodies were weighting the quality of life more, the other ones just not even considering. So again, also from, in terms of equity in access to this drug, I think are some consideration to do. Items for regulatory purpose, again, these are very important because we have overall side effect impact, and you can see that EORTC and also the FACEIT item library, they have now from FDA and EMA the focus of incorporating the single question about what extent have you been troubled with side effect from that specific treatment. You can see that even from the ISOQOL, which is International Society of Quality of Life Research, we try to respond to the FDA guidance of implementing patient-reported outcomes into clinical trials, because the collection was, yes, they were defining some core item to be implemented, but still no collection of PRO data in early phase and potentially accelerated trials. And that was the same because when you look at the European EMA approvals, so only 17% oncology indication were including PROs. So again, missed opportunity. And we had also this workshop with the EMA and EORTC to integrate potentially this cost effectiveness items within the evaluation, but without bothering the patient too much with all these questionnaires. So the agreement was that for example, from an EORTC perspective, from the EORTC C30, you can now have this C10D, which is used as a health utility score. So without adding, for example, the EQ5D that was the most commonly used, you can just derive your utility score from the EORTC. So I think this is a little bit better. And to conclude, just to mention that in our setting, in the resectable space, we demonstrated that, of course, all these informations are very important, again, to define the best tool to evaluate these trials and potentially in clinical practice. But when you look at the information that were exchanged in real clinical practice, the patient was not very happy of which information we were providing. So definitely in terms of lack of shared decision-making was definitely referring to the lack of information about quality of life and lack of potential alternative treatment proposed. So to conclude, of course, there's no perfect tool yet, but the one that we're really aiming should focus also on physical and social and potentially psychological factors that can influence potentially the treatment, because this will help to select at baseline, I'm sure, personalized treatment with all the operability and staging and biomarker. So we are trying to, within the ISLC, we are happy to have this, it's a PRO, but quality of life-based project to give some direction in terms of what to measure, when, and especially in theory with a good instrument that can assess holistically all these other factors. So thank you so much.